Okay, welcome to our next session. So as I've mentioned already, because this is a tight fellowship, we are trying to pack in as much as we can. So we have a panel, but each person on this panel is going to talk about something a little bit different, but overall it fits under the wider umbrella of what people who are actually in these organizations, what are they doing to help? What are the obstacles they're facing? Those sorts of things. And I know I've already heard some questions about EAPs, some questions about apps, and their effectiveness. And so this will also give you the opportunity to ask questions of people who are directly involved in those things. So first, I would like to introduce Kathleen Crowley. Kathleen is the EAP Clinical Manager at Adventist HealthCare LifeWork Strategies. She has 35 years of experience working in mental health. She's an LCSW herself. She's worked on EAPs from the Postal Service in Baltimore to Adventist Health currently. And she's lectured on topics from Stop Postponing Your Happiness to Workplace Violence and Moral Injury, a Survivor's Guide. So she has a lot of experience in this area that she can speak to. Lauren Magoun is the Senior Health Strategy Specialist at Dimagi, where she researches and develops ways of improving mental health care access at a global level for frontline workers. And she'll talk a little bit about how they define frontline workers and what they're doing for people who are in places where care is difficult to access. And then we have Danielle Hayes, who has 17 years of experience in HR. She is the HR director for Milk Corp, which has been rated one of the best places to work multiple years in a row by Fortune, by Washington Post. And so she can talk about what they do to make their organization successful, and also what happens when someone is not feeling at their best. So please join me in welcoming this panel. Kathleen, please feel free to. Oh, sorry.
It's okay. I am very short. I'm actually going to stand if that's all right, so that I can see the slides. So I have been doing this for a while. I've been doing clinical work for about 35 years, and the last 10 have been in employee assistance programs. I like the idea that I get to speak about things that I'm really passionate about. And in my current position, I have the privilege to serve many organizations, both the Adventist HealthCare organization that serves around 6,000 employees, but also we are the EAP for about 50 external organizations. And so I get to have influence and impact on mental health and well-being of healthcare workers, but also workers of other industries. Here's just a little something that I wanted to try and get across based on the questions that were sent to me about giving a little bit more information about what EAPs are, where they come from, how they work, how their effectiveness is measured, and then some common misconceptions. And I can also entertain questions around barriers like you had mentioned. So the history of EAPs is kind of fascinating. It was born out of Alcoholics Anonymous. So back in 1939, when AA was formed, people started to sober up, and in their recovery, they started conversing with one another and helping one another to recovery, to sobriety. And this spread from kind of the Midwest to the Northeast part of the country, and talked about how, workers can go into recovery and sober up and then be productive again in the workforce. And if you think about prior to that, it was normal to drink. It was normal to be drunk. It was normal to drink at work. I think of my own father in the 1960s who was a salesman. What did they do on lunchtime? had cocktails. My father would entertain his clients over martinis. That was commonplace. And so when they discovered that people would sober up and become more productive, that became kind of a thing where employers started to sit up and react to this phenomenon. And then along came Senator Hughes, who was a recovering alcoholic himself, and he introduced the idea of the Hughes Act, and that became a bill. And that was the idea that employees needed to have a place to go if they needed something, if they needed help in some area. And then the National Institute on Alcoholism and Alcohol Abuse was born in 1970. This brought in the idea of prioritizing mental health and mental well-being to federal and state employees, and it created a lot of grants and a lot of money to support that concept. So along came Dr. Massey, who was at Boston College, and an alum had contacted the dean, as the story goes, an alum had contacted the dean at Boston College about these employee assistance professionals, or programs actually, that had come about. And that maybe somebody should take a look at this person, Otto Jones, out in Utah, who was creating some of these programs. And the dean brought this to Dale Massey, and she started to create her own training programs as well. And then the Secretary of Health and Human Services had some monies and said, come on down to Washington and create these for federal employees. So that, in a nutshell, is kind of where the EAP programs were created and existed, and now they're not just for federal and state employees, as we know. They've gone out and branched out in other industries because they see the value of them. I know I have a very short amount of time. I get a little excited. So I'll go through these. The purpose of EAPs is to make people more productive, more creative, keep them in the workforce, to decrease absenteeism and presenteeism for employees that are just kind of just showing up. And improve job satisfaction and morale. Again, if we can do that, we have a better working company. We have a better industry. If my employees are happy, the workforce is happy, the product comes out better. There are different models to EAPs. So there is an internal, a hybrid, and an external. Internals are employed by the organization, and they conduct all the counseling and things like that within the organization. The external are contracted out. Then there is what's called a hybrid model. That's what I do. We have an internal model that myself and my team serve our organization. We help them with critical incidents, with the death of a beloved employee, with maybe a bad outcome that happens medically, workplace violence issues that we know are on the rise. We help them with that, but when it comes to their session model for counseling, we'll contract out for that. So that's the hybrid model. So how do we see our effectiveness? Well, the thought process is that we're increasing productivity and creativity and all that, and we look at those indicators around stress levels. Are they satisfied in jobs? Are they being retained, excuse me. Are they staying in the game as well? And so we look at currently our vendor for our data collector has benchmarked a number at 4% right now. The Employee Assistance Professional Association does not come out and say that they have a standardized way of benchmarking utilization because it's hard to compare healthcare with banks because there's different, maybe one is more male dominated, one is more female dominated. We know females seek out mental health more than maybe males, and that is changing, thank goodness. But size of industry, location of industry, all those things make it more difficult. What our vendor does is they are comparing healthcare systems both in the nation and around the world, but they're collecting the data of clinical utilization along with our work-life services. EAPs also offer not just counseling, that's one of our misconceptions that I'll get into, but they also offer work-life services like childcare resources, like dog walking services, like I've just moved into the community, what's available. Legal services are huge. When you think about the personal impacting what's happening to them at work, maybe they're going through a divorce, maybe they're going through an adoption, maybe they're buying a home and they need services, we can help them with that. Anything that impacts them mentally and emotionally and their well-being, we can help to influence and help them improve that. So we don't only offer counseling. There's a fear that EAPs aren't confidential because if I'm employed by my, if I'm employed by my organization, then how can you possibly not be speaking to my boss and telling them all my dirty laundry? Well, we abide by HIPAA, and there are laws and there are ethics saying that I cannot share your stuff, and I really value putting food on my table, and I'm not going to risk your business and not be able to continue to do my job. And again, we want them to really understand the confidentiality so they'll continue to seek help. So that, especially when we talk about substance abuse with frontline workers, healthcare workers, first responders, police officers, we really go forward with them when we approach them about the importance of confidentiality because they fear it the most. That's it. Did you want questions now or after?
I think we can take a couple questions now.
So on confidentiality and privacy, can you, what are those misconceptions? And you talked a little about HIPAA, and how can journalists cover EPAs in a way that is responsible? That talks about EAPs in a way that's responsible, that helps people learn more about those other services other than counseling?
It's a great question. I think the answer is that I can speak generally, right? I can tell you about the data. I can tell you about the programs that we develop. I can tell you about our utilization. I can tell you about how it's being used. Also, I can tell you stories, but I'm not going to use any identifiers as well, so that I'm still protecting people. When we're applying for new contracts with other organizations, we will tell some of our really good, successful stories, but we're protecting PHI, the personal health information. And then, of course, we're always going to share our data about how successful we are. The benchmark that we use is 4% for utilization, and our current utilization is at 11.86. And in the last 5 quarters, it hasn't gone below 8.77. And during the pandemic, it was 18.75. And so we can share information like that. And the fact that we are internal and we are inside the organization, we understand the culture. We get to know the people so that they build trust. And that's where the confidentiality comes into play, too, when they really trust us.
Can you talk some about how these programs interact with mental health care coverage more generally, insurance coverage, and how they work together, how maybe they work against each other in some instances?
I don't think they work against each other, but the beauty of EAP is that we don't go through insurance. These are prepaid session models that each organization will purchase ahead of time. So for my internal candidates, or my internal organization, Adventist HealthCare, they have a 6-session model. That's all prepaid. So that's a real selling point for our physicians and our nurses that are afraid that if they disclose maybe I'm drinking too much, it's not going to go to their license. Also now, because I've been in it long enough, I've seen the evolution of substance use facilities and how greatly they protect and build specialized programs just for people that are extra worried, like the police force. I'm afraid they're going to take away my gun if they find out that I'm having issues. No, they have programs to keep your identity and have special groups that are just for you. And so then when it does get handed over that they might need more longer term services. EAP is meant to be short-term goal focused. When it's more longer term, then it gets handed over to insurance. But again, if you're talking substance abuse or anything like that, or mental health, the social workers in the hospitals and facilities really know how to document in a way that they're there for a medical need. Did that answer your question? Great.
So I know that you said that confidentiality is something that people think is a bigger concern, but I do know that when companies are sort of contracting out this work, there is some anonymized data that can be shared, and I think employees are not always aware of that. So if you could speak to kind of that issue more, and how do you also ensure that employees are aware of what may or may not be shared, and what the level of confidentiality is that they have. And then sort of related to that, a few speakers have talked about like good versus bad EAPs, and I wonder if you could share a little bit more about that. I'm sorry.
How dare you? So communication is key. I think communication about confidentiality is primary, and we lead with that. So right now in my organization, we've created a program around burnout and resiliency, and we've shown a measure of success in those areas. We let all participants know you are protected. We are not going to share with anyone that you are participating in our program. You can share that you're participating, but no one else can. Our data that we're collecting, because we're doing a pre and post survey and collecting the data will be shared so that we can grow the program more, but you will be protected. Now, the good and the bad EAPs. Don't get me started. So here's my opinion. I think I understand why industries go for that external EAP. It's cheaper. And money talks, and I get it and I understand it. I'm very passionate about the work that I do internally with organizations, and even with our external organizations, I have relationships with our points of contacts, with our HR people, that they know they can come to me and they can ask me, I've got this issue, what should I do? And we do management consultations. I get to know the culture, and my team gets to know the culture of the organization for whom we're serving, and we get to know the people. You can't take that away from anything that anybody does in this world. You've got to know people. And when you do that, you build the trust, you build the bond, and that makes for better utilization. And we always want to drive the utilization because we want to help the employees. We want them to come to us and trust us. We want managers to come to us and ask our opinion. When you go to the externals, if you quote me and tell me Kathleen Crowley said externals are all bad, I didn't. What I'm saying is I think there's a greater benefit to having the internal or the hybrid model, because the externals just don't get that human touch. They're usually embedded in the insurances, and that makes for people calling in saying, I need this service, okay, here you go. Where when they call us in, we might know Nurse Betty on Unit 4D, and we've known her because she's used us a few times. Hey, what's going on this time? Did you know that we have a service for that? Let's get you hooked up with your counseling. Do you need us to come talk to your team again? That sort of thing. Do you see the difference there? So not good and bad, but one might be a little bit more involved. Fair?
Great questions. You'll still have time to ask Kathleen questions, but let's move on.
And I'm going to talk to you a little bit first about where I work, because it's kind of an unusual place and probably unusual in terms of who we're hearing from today. And then who we serve, who are our customers and clients in using our programs, situate that in sort of how I think of workplace mental health in my work, as well as talk a little bit about equity in workplace mental health and who actually has access to HR at all, and any of these sort of benefits. And then wrap up with an example of some of the work we're doing at Dimagi to bring actually a digital app to build resilience and well-being amongst healthcare workers in lower income countries, which is a group that does not get much focus. And I'm going to tie to a lot of parallels, hopefully, to the US as well. We do work in both places. So actually, I should go back. So Dimagi is a technology company. We're a B Corp, a social enterprise, and really do have an impact first ethos of how we work. And we build digital apps and web apps for frontline workers around the world. We originally primarily worked in lower and middle income countries, and actually out of COVID, we now actually have a large US health presence for a variety of fun historic reasons, if anyone wants to talk about that. And we have a vision of all people have the access to the frontline services they need to thrive, thus us building apps for this group. So when I say frontline workers, and I'm going to use this term a lot, and it means different things to different people, I'm generally talking about folks like community health workers in lower and middle income countries who are primarily women, often not paid at all, sometimes paid small incentives, and are actually the main point of contact to the healthcare system for billions of people, sometimes the only point of contact. And they deliver a lot of routine care, maternal child visits, sometimes routine immunizations even, managing common infectious diseases and the like. And as I said, these folks generally are sort of in the formal sector, they're sort of between the formal and informal sector, and don't have a lot of sort of job protections and the like. And that's primarily who uses our apps. Like I said, we also now have work in the US and work with frontline workers in state and local health departments and NGOs and sometimes in healthcare systems as well. So because we work with this sort of underserved workforce, or those are the people who use our apps, we really actually made it part of our strategy to improve their jobs. So we think part of our mission as an organization is to build apps for these folks, as well as figure out how to actually make their jobs better as well. And we're doing that in a variety of initiatives. I'm going to talk about one with this app for building resilience, but we have some other work as well. Taking it back up, sort of the big picture, how I think about in my work as a researcher, mental health at work, I sort of posit it in two buckets. One, amazing things like making sure people have the right health insurance and access to care and EAPs and the like, and supporting workers who might actually have mental health conditions, which is about 15%. I'm going to talk a little less about that, but I just want to point out that is super, super important. I more work in the part of creating mental health promoting workplaces. So having a good job where you're doing skills that you can do, seeing value in your work can actually be preventative of mental health conditions to an extent. It certainly makes people's lives better who are in those workplaces. So that's sort of where we work, is sort of building apps to help support better jobs, including some wellness activities. And there's a great World Health Organization mental health at work report that came out 2 years ago that's sort of agnostic to global mental health at work, if anyone's looking at non-US settings. And given where I work, I'd be remiss not to point out the equity issue in just the topic of workplace mental health. According to the International Labor Organization, 60% of people who work in the world work in the informal sector. So if every private sector or public sector job had the best everything, it would still only be reaching 40% of the world's workforce. So there's all those people out there that don't have HR, social, any sort of protections. I don't want to belabor that, but I like to think about it in a global population health sense that is true. And I'm sure you're hearing about this a lot today. It's also true in the US, though we have a much smaller informal workforce, although there is some of that. There's huge disparities in access to both basic health insurance, and even if you have health insurance, can you actually get care? Is it too expensive, or there's no appointments? All that stuff that I suspect everyone else is probably talking about. But also in terms of things like corporate wellness initiatives, there's big disparities in who has access to that. So like hospitals often are leaders in this area and have great wellness activities, from mental health care to screenings and promoting physical activities. But if you look at the data, smaller organizations, companies with 100 or fewer employees, are much less likely to have access to any of that. I think that's increasing slowly over time, but I found a comprehensive report, which was a few years ago from the CDC. I suspect it's higher than this now, but it was only about 10 to 12% of small employers gave access to wellness, comprehensive wellness to their employees. So I just like to situate that when we're talking about a lot of these things, it's often only for a small percentage of workers. Okay, off my little high horse there. So what are we doing at Dimagi? We have been developing an app we call WellMe, which the idea is to reduce the impact of burnout, particularly in the frontline workers I was talking about in lower and middle income countries who they often don't have good supervision, they often don't have training, and we, as sort of a third party, can't solve that. We can sort of advocate for it, but what we can do is see if we can develop scalable, culturally relevant local tools that brings evidence-based practice to them to address burnout, which of course you probably heard a lot about today. Lots of bad things when people are burned out for themselves, for loved ones, for the care they're providing, right? If you're completely burned out, you're probably not always giving the best care to the people you're working with. So that's not good. So, like I said, what we're trying to do is bring evidence-based approaches from the field, from the literature, from other organizations, combining that with our background in adapting things for local context. So working with our partner organizations to making sure it's in local languages, there's local examples, and that it makes sense for the people using the apps. Because of course, if people don't resonate, they just won't use it, and then there's no point in the app at all, right? Like that's the key part of actually getting people to use it. And making sure it's scalable and cost effective so we can actually get it to people who need it. So the app is based on sort of these 5 core buckets of content, none of which are radically innovative, I would say, crucially important and based on good evidence. Stress management, self-care, connection to others, mindfulness and relaxation, and connecting to purpose, which is really big in healthcare. Sometimes people lose sight of that, and when it comes back to like the important work they're doing, it can be really helpful. And in the app, we have a number of features. We have learning modules, we have short videos, examples of what that content area is and why it's important. And to be honest, this is actually sometimes very new stuff to the people we're serving. In our US ethos, it's very common to talk about self-care. You see it on social media, you see it here. Some of the workers we're working with, this is kind of a new idea, not for all of them, but more so than in the US. Practice, we encourage practice of some of these skills, so there's ways to go back to the parts of the app they like. If they want to rewatch the video on mindfulness, they can. We have them try to set goals, like I'm going to go for a walk 3 times a week or whatnot. And tailored to individual preferences, so they can go and they can select what they're doing when, and it also tracks their progress over time. So there's some gamification, how often they're using it, encourages them to use it more. Once again, these are things you see in a lot of apps, but we've tried to tailor it with our partner organizations for the people using it. And there's a referral pathway for that we work with our partners to make sure people have serious mental health conditions. This app is not going to cure your severe mental illness by any means. And so we're actually testing our hypothesis that getting people to actually use the app through creative engagement techniques will build resilience. We have a number of research studies actually out there now that are sort of in progress or towards the end. So unfortunately, I don't have hard data. I wish this was like 6 months from now so I could show you. Hopefully, it does wonderful things. And we're also checking how cheaply we can share this, because we hope that not only does it help the workers, but that the NGOs we're working with will see better retention and potentially better outcomes. So we'll be looking to get funding to sort of research that longer term as well. And yeah, just in summary, right now we're testing with 500 people in 9 organizations in India, Uganda, Nigeria, Kenya, Malawi, and Ethiopia. And we do have some qualitative feedback actually already I should share. A lot of people seem excited because they don't usually get their employers trying to make their job better or care about them as people. A little bit depends on the partner organization. Some are better than this than others. I don't want to paint too broad a brush, but it's much less part of the culture at small NGOs or government organizations in a lot of these countries to do this sort of work. And in some of the partner organizations, we've encouraged them to sort of have coffees with the people who are using the app or chat with each other, which also builds that social connection and makes them feel like their organization cares about them as well. So yeah, in sum, mental health at work is critically important. Everyone in this room probably spends a huge part of their life at work. I'm thrilled EAPs exist and they're doing a great job, and lots of people don't have access to them around the world. And that we think digital tools can be a part of the solution. I should have said this up front. I don't think, at least as of today, any app is going to solve everyone's workplace mental health of any definition problems, but it can be part of the solution. And I think long term, in terms of the app, figuring out what works well for whom is going to be the challenge. It sounds like earlier people were asking about apps, and I can try to talk a little bit about the evidence around apps, but it seems like some of them work really well for some people and not at all for others, and figuring out for whom it works best and why, I think is going to be the medium-term way forward, because we don't have enough people to, when we're talking about real mental health conditions, treat everyone. So if we can get to the people who the apps will support first, that's awesome, and get the people for whom they won't work at all to in-person care quicker would be great. And you should all call me out on all the jargon I used that you probably didn't know what I was saying.
Thank you for your presentation. Can you tell me about the uptake of the apps in those countries versus here?
Yeah, so We are partnering with local organizations, so they're giving it to their employees. So it's not, we're not, we at Dimagi, at least for the immediate future, don't expect this app to just be on the App Store for someone to download. It would be part of an employer of some sort giving it to their employees, which I recognize goes against my informal sector spiel earlier, but that the downloading of apps in this sort of sector is kind of a rare thing.
So why would they be on the regular App Store?
So there's language barriers, for one thing. Most apps out there are in English or European languages. So if we do it in Tigrinya, which I might be saying wrong, and I apologize, which is the what they're speaking in the Tigray region of Ethiopia, like there aren't apps in that. And also, to an extent, the frontline workers we're working with are of mixed literacy levels. So if most US-based apps, honestly, are designed for me, right? Like higher than average income person in the white collar job. And so the form factor is designed for them, and it's less engaging generally for other people from different backgrounds. The examples don't resonate and the like. Does that make sense?
Yeah, and you mentioned that you can give us information on the studies of these apps.
Yeah, they're in progress. We 100% will share. Some of them will be even published probably in journals. I can refer you to some of the in-progress work we have on our blog, or I can talk to you after about in-depth what's happening.
We see sort of like data breaches coming from companies all the time. What sort of privacy features are built into these apps to protect health information?
Yeah, no, that's a great question. So our main product is something called ComCare, which is a no-code platform or low-code platform to let people build mobile apps. So our actual core product is actually content agnostic. Any of you could use it if you wanted to build an app for data collection and case management. And that is built on, like, we have all the, I'm not the tech person at the company, but we have like SOC 2, and it can be HIPAA compliant. We can give people business associate agreements. So we take the data very seriously. Protection, we have, I mean, tons of data from other programs that we have that include, HIV status, very, mental health status, very stigmatized things. So we treat it like medical information. I mean, generally, each project's a little different, to be clear, but generally speaking, we keep all the information on the back end, just like any sort of health tech company. To your point, we try very, very hard to keep security up to date and have really a deep philosophy of that, and consider security a process and not a project, and there's a whole theory behind it. So yeah, I mean, we try as hard as we can. I can't say sort of more than that, I guess, that we do treat it like health information.
I wonder your perspective on sort of the lay of the land of other apps that are more widely available. Like, what do you think makes some things work and others not?
Yeah, no, that's a great question. I think there's a number of things. I think some people base so I think in the US, a lot of apps, there's a big variation of how they're funded and why they're funded and for whom they're funded. So I've been working in sort of digital mental health primarily in lower middle income countries for about 3 years. And even in that 3 years, I've seen a lot of apps that started off being for sort of the general public switch to being sold to employers. Because it's easier as a sales pitch, right? You only have to go find 6 employers who have big contracts versus selling individually on an app store. And differentiating on like the public facing is really hard. And part of that is, is they have VC funding, and part of it's just ease. So like there's a lot of like structural reasons why certain apps, like to me, they're all converging. A lot of them are all now adding the same content and engagement and being sold to the same places. And I think personally, that's a lot because of business decision making versus it works better that way necessarily. I think right now we're at a real inflection point with large language models. I think a lot of the apps that everyone's using today and yesterday are going to be radically different in 18 months. I could be wrong, but that's my prediction. So there's sort of that whole thing as well. And I think some companies knew that was coming, so there's that. But in terms of what works, I think engagement is the key, right? If you're not using the app, it's not gonna do anything. It doesn't matter, it has the absolute best content in the world. And I work with a lot of researchers, and I think they get that wrong sometimes. Like, they're so in the weeds of the clinical evidence, and you can't change it even a little bit because the study says this, that the apps end up being very boring because they have to like stick to the IRB protocol from 3 years ago or whatever. So that's one issue, is I think some people don't pay enough attention to engagement. And other people, I think, pay too much to engagement, not enough about content. So that balance, I think, is tricky, and it's expensive to get that right.
Let's go ahead and move on to Danielle, and then we'll have, okay, one more.
I was just going to ask really quickly, you mentioned how this is given from the employee to the, or from the employer to the employee. Do you think that might make any employees a little nervous about maybe asking for that app, or maybe making sure that they have enough time with it, time to engage with it, confidentiality, or do you think that has any concerns for them?
Yeah, so I think yes, that is a concern for some people. In this case, I mean, a lot of these organizations here, I think the workers think it's kind of cool because it's newer to them than it would be in the U.S. In these cases now, it's voluntary, so people can do it or not. And because they're part of studies, I will say right now they actually get most of the sites, they're actually getting a small amount of money to test it because it's part of a research study. And that's actually what we're trying to figure out long term, would it actually be good for companies to pay people a tiny bit to use the app? I mean, there's I don't know. I think there's big potential downsides and there's potential upsides. So we're actually figuring a little bit that out as well. But right now, like I said, it's a little bit under research prototyping, so it's not quite real world implementation. I think in a lot of settings, they're less worried about data breaches and such because they're not as familiar with it being a problem. I mean, we try hard to keep it to the highest standards, but I think in these settings, we get fewer questions than we would in the US. Maybe for the worse. You should be asking.
Thank you.
Okay. No, I do not have slides actually, but I am still going to stand up because I'm getting a little step up on that chair. So thank you everyone for allowing me to participate in this discussion. I think it's really great. And I also think me going last is a really great segue because while it's been discussed and shared that looking at different tools and resources such as an app and EAP aren't the full 100% solution to specific issues around mental health and burnout, my perspective as an HR director is really designed around employee culture. Because what our belief is at MIL is that while self-care, meditation, gym memberships, all of those things are really fantastic. When you really look at kind of the feedback that we get on a regular basis, specifically from employees that are exiting the company or even during the hiring process as far as what they're looking for, what they want is a culture and a workplace where they feel valued and respected. Because the fact is, stress is everywhere, both in and out of the workplace. Even some of the most wonderful and meaningful life events, such as getting married or going on vacation, inherently have a points indicator centered around stress. So what can we do as an employer to help reduce the stress, which, over time, without any sort of let up, can lead to burnout? What can we do for our employees to help prevent that, right? And so what we tend to focus on is looking at the practices, the policies, and all the different dynamics and norms within each of our teams, and also at a corporate level that contribute to employee satisfaction. So in the intro, we were cited as one of the top workplaces. And if anyone has ever participated or been on that list as an organization for Great Place to Work, they do a very deep dive in terms of what the employee experience is like. What is it like to be on your team? What is it like to work with your manager? What is it like to show up each and every day? So what I'm going to start with is where we start with the supervisory management front, as far as how do we instill in you what our culture is and what our expectations are as far as employee treatment, workplace environment, and really how do you dig into what's going on with your team. So about 2 or 3 years ago, we partnered with a company called Pathways, which brought to us some mental health coaching and training to all of our supervisors. And they gave us a lot of good information about dealing with employees in crises, what to ask and how to approach. But specifically, kind of what we took away very simply in terms of the continuation of that training was what we call ask, notice, listen, right? And we teach that to all of our supervisors, and we engage them to really look at what's going on, and you can find it in one of those ways or all three of those ways. And that would be first, you ask. And you can ask verbally if you notice that there's a difference in kind of how an employee is showing up, whether it's due to, you know, their appearance, or, you know, how they are participating in meetings or disengaging. And then you notice. Sometimes it is not so much because you asked from a survey or you got it from some sort of exit interview, but you're just kind of seeing a shift from how the employee once behaved or how they kind of worked and were a part of the team, and they've gone from one extreme to the next. And then it's listening, right? So people are talking to you in a number of ways, even if it's not verbal. So we do 6-month check-ins with all of our new hires. We also have focus groups. We have what we call state interviews, because we're trying to identify what is the cause of any sort of discord. Because at the end of the day, even if you have the best life outside of work, if work is stressing you out, that can lead to a potential mental health issue, mental health crisis. So with that being said, the Ask, Notice, Listen approach has gained a lot of traction. A lot of our supervisors really had to get to a point where they were comfortable with engaging in employees and having those conversations. And that really, there was no magic bullet to that. It was really about engaging the human resources partners that each of them have assigned when they have a problem, when they notice that there's something wrong, or if the human resources partners, just in receipt of the data, have identified something being potentially problematic. So with that, we work with them to look at what accommodations can be made for an employee, even if it is not recognized as a full-on disability under the EEOC. Because if there are simple things that can be done, whether it's moving someone's seat because they're in a high traffic area and it causes them anxiety, like, we don't have to go through the interactive process to do that. That's something very easy that we can do to accommodate. Now, I will say, post-COVID, we have gotten a lot of requests to work remote. Our business is very different from other organizations that really may have to be out in the field. We have about 800 employees nationwide. Many of them work remote 100% of the time. The others are kind of on a hybrid schedule, coming in based on client requirements 1 to 2 days a week. But that being said, we really encourage everyone that is supposed to be on site to come on site. And if they are indicating some sort of stressor, some sort of issue, we work with them to identify alternative solutions, because we don't necessarily want everyone to believe that going 100% remote is always the answer. Another thing I did leave out is conflict resolution, identifying the bullies, because yes, the high school bullies grow up and they just go into the workforce and stress all the other kids out just like they did in the hallway. And so, you know, we deal with that very swiftly. But again, it is also getting the managers to a point where they engage the HR team to say, hey, this person is a problem. True story, 2-3 weeks ago, we had to let a guy go because he threw a chair in a meeting back in October and nobody reported it. And then once we found out, we're like, you know, that doesn't work for our culture here. Like, no wonder, you know, you've got this poor guy over there having nightmares because he's got to deal with this person on his team every single day. So. Again, you know, my perspective is, you know, all about how do we treat people? Do they feel seen? Do they feel respected? And then in that, the stress and burnout is reduced. I advocate for self-care. I advocate for taking time off. But if I come back to work and I still have the same mess I left with, that vacation is way in my rear view at that point. So. All right.
Thank you. Let's take a few questions for Danielle, and then we can open it up to the full panel. Oh.
I'm curious about the impact that these trainings and this culture has had on the company, you know, specifically things like retention, turnover, satisfaction. Can you speak to that?
Absolutely. Well, Where I think the value has been is that people recognize that we have zero tolerance for a lot of the bigger bad behavior, right? Everyone is not going to necessarily fall in line in terms of what we expect as far as their communication style and their approach. You know, you find a lot of professionals in executive leadership roles that have had zero experience or training in leading others, right? And so we want to work with them in those areas. But when the teams and the employee sees that the organization is taking it very seriously, then they in turn take it seriously too. And so the feedback we get from the human resources partners is really more about the traffic with the inquiries, with more people wanting to set up meetings so that they can have these conversations, because they're hard to have if you're not used to having them. And so that's the success of it. And when we go back to those employees and we ask them about job satisfaction, which we do every year, then our scores continue to go up.
Could you speak a little bit about how to hire well? Because I feel like part of creating a harmonious culture is being good at hiring.
Yes. So my short answer is competency-based interviewing. And what that is it's really identifying what has been deemed success factors for a specific role or team, and then really allowing the candidate to speak to those experiences. We do have one particular area where it's very hard to hire people, if I'm being very honest. And so what ends up happening is you get what is called similar to me hires, where it's, you know, I knew this person, they're on my softball team, they have the certifications, and then, you know, you get kind of the stars in your eyes because on paper they look good, right? But I would caution any manager to hire that way because, as you know, they say you're looking for the right fit. Because even if they have all the technical capabilities, if you did not ask the right questions around how they communicate, past experiences, give me behavioral-based examples of what you did in similar situations, and then those answers don't align with what you know to be successful, then they're already giving you the red flags, and then at that point it's like, are you going to pretend they're, you know, yellow or pink and hire them anyway?
Just one thing I took away from that story you told about the guy throwing the chair is that nobody reported it. I'm wondering why that was, if you have the culture that you were talking about.
Well, I think what happens is people will sometimes minimize an experience when they're going through it. I mean, we see it just out in the world where people will press charges for something that happened, you know, 3 or 4 years ago. In this instance, you know, I think they were dismissive, the people that were there, of the behavior. But then when, you know, the person kind of shows their true self in a different way later on down the road, all it takes is one individual to say, you know, enough is enough. We can't tolerate that.
So how do employers overall like earn that title top workplace? Is it like based on a survey, or is it because of low turnover, or is it several factors?
There are several factors. So the survey is probably about 15 pages long, Rhonda. I have my VP of communications here with me. And so Great Place to Work, what they do is they kind of do a deep dive into everything from the benefits offered to the manager styles, how issues are reported, do they let you bring your pets? So they kind of give you points based on everything that you know, an employee could recognize as important and meaningful, and then based on all of those submissions, they give you the ranking.
So I'm wondering, for HR professionals and people who work in supporting workers, what can they do whenever you don't have the support from CEOs and executives in creating this culture? I'm specifically thinking for state employees in Alabama, like the retention is really low, specifically like in state employees that work in child welfare. So so it's but the state doesn't really like pass laws to create benefits. So what could those state agencies do to support state employees when the legislature doesn't act?
So that's a really great question. And really, when you think about most of the laws that we have, they were passed because the working conditions were bad. It wasn't out of the benevolence of, oh, this would be such a great idea. Let's make sure everyone can use the bathroom of their preference. No, it's because they were not allowed to. So to answer your question, it really kind of becomes more of a grassroots approach. One of the things that we experience at MIL is, we've been trying to kind of create this one unified culture. But we recognize that we have a lot of subcultures within the organization. Just because you have a sect of people that work in Southern Maryland, then you have a sect of people that work in Charleston, South Carolina, and they kind of create their own norms and dynamics, and we're fine with that. But there still is an umbrella standard of what is allowed and what isn't. So I would say for an organization that is experiencing kind of like any sort of poor treatment, unfair workplace practices, typically the change that you might be referring to typically comes when there is a financial loss involved. Even with the best protections, if there's some sort of violation and it goes into litigation and the employer is found at fault, if it happens enough times, they deal with it. So.
We had a speaker earlier who was talking about kind of the spectrum of mental health from extreme severe mental illness up to, thriving. Going back to sort of that side of things, when there's a mental health crisis, when someone has a mental health crisis, and actually this would be good for you as well, Kathleen, what is the process that you all go through? Obviously without specifics.
Right. Yeah. I would say we don't have a set process. I will say that. We don't have a set process. We've had employees that, the managers have identified as, something might be wrong or there might be an issue. And they're like, should I call their emergency contact? And then, for me, I'm like, no. Because we don't know what the dynamic is. We don't want to violate her privacy. That emergency contact is strictly there if there is a specific issue at work. We can do all the coaching and counseling, make the referrals, but in terms of an actual execution of a crisis plan, we do not have one at this time.
I can speak to it. First, I wanted to say that I 100% agree with you about the culture and how important it is. We too have been, best place to work, and I see the culture as having the respect for their employees and supporting the mental health component and recognizing, especially in healthcare after the pandemic, how important mental health is. So I really support what you said. It's so imperative that the culture matters at the organization. As far as a process, again, it goes back to having those established relationships. So I can tell you stories about where we've had our own employees go through mental health crises, and the manager who knows about the EAP, who trusts us, will call and say, I got somebody in my office. They're saying, if they went home today, 100% they would kill themselves. And the beauty, again, of having the EAP in the organization, back to your question about good EAP, we've built these relationships with the case managers in the emergency rooms and with the vice president of behavioral health. And I can contact them and say, I've got one of our own. They're on the health plan. They're asking to stay. They want to go to our behavioral health. Do we have a bed? Nope, but we'll make one. Okay. And then we'll contact the needs assessment person in the ED. I got a red carpet. Can you treat them like a VIP? Absolutely. We'll take them off privately and we'll do. So we have this process in because people know to call us, and then we're able to handle them with real kit gloves in a confidential space, knowing that we're taking care of one of our own. So we've had instances with real severe mental issues. Or just the opposite, maybe their external issues outside are so impactful, like an employee who's living in their car, and the supervisor finds out. They call the EAP because they know that we're resourceful, and we were able to get them all that they needed and get them out of their car.
So I specifically had this question in mind for Lauren, but I think it should be open up to everybody. Just in regard to your work in other countries, I was wondering what you have seen or what the app includes as far as acknowledging and responding to some of the global conflicts that folks in those countries are seeing. I mean, right now, folks in Kenya are seeing a flood of refugees from Sudan, and also how that translates to employees in the U.S. who are increasingly stressed about not only international conflicts, but even the election this fall. Rising tensions around that. So just the broader question of beyond the individual level stresses about my job and things that are going on at work, those larger scale tensions and how you can deal with them effectively.
Yeah, no, that's a great question. So in sort of global health, there's actually a subfield called MHPSS, Mental Health and Psychosocial Support Services, which is it's like almost a subfield of global mental health that works primarily in emergency response, refugee camps, high trauma sort of situations. And there's a number of things they do. They both have some sort of set session-based programs to work with the people directly impacted by whatever the trauma is, whether that's war or floods or whatnot. And then there's also, I'd say that field of mental health is actually pretty good at supporting the workers. So there's a number of, most NGOs and organizations that work in that setting do recognize how traumatic it is for the workers and both the refugees. There is something called, for example, psychological first aid, which is a very simple intervention you can teach people who are working with folks who've experienced a trauma. So if their house is burned down or they're in a refugee camp, you can Google it, psychological first aid. You could all take a training online. It's very, very short, and you can learn how to sort of coach, I won't say counsel, because it's not a clinical intervention, but work with people in that situation. So that's like a quick intervention that a lot of people do. Our app that I was talking about there is not specifically designed for those settings. It's sort of more for general healthcare workers who work in these sort of settings. I do think people who work in those acute traumatic areas do need more than that. And I actually think we're not making a product specifically for that, although a lot of people in those settings actually use some of our tools for actually delivering care and care coordination and the like. And then also just to put out sort of in the global mental health space, which is actually where I spent most of my time, is trying to figure out how to use apps to support scaling mental health care in other countries, not for the workers themselves, but how can the workers delivering care have apps to scale and spread their work. I didn't know this till I started my current job, and I had a background in healthcare and public health, but there's a number of evidence-based interventions where lay counselors can deliver counseling support for moderate depression, anxiety. There's transdiagnostic approaches that sort of do all these things, and they're manualized and protocolized. So you can go to the World Health Organization and download interpersonal group therapy, and there's a whole manual on how to train people and deliver like a 6-session program to address some of these issues. And interestingly, a lot of the global health researchers I work with are now trying to bring some of these protocols and ideas to the US, because we, of course, also have a lack of specialist providers. And this is only for certain, it doesn't, kind of like the apps, they don't all work for everyone, but actually therapy doesn't work for everyone. I mean, specialized therapy doesn't always work for everyone. So figuring out who, where, and how you set up a stepped care approach is really critically important. And your point is well taken. There's definitely lots of people in the US affected by global things. It's not something we work with a lot, but I hope companies have EAPs and other things to support them in that situation.
You were talking about the process of getting somebody into the hospital. What happens getting them back? Are you reluctant to get them back? Do you work with best practices from the hospital guidance, and what happens in general at other EAPs? I mean, you're connected to a hospital, so you can do that red carpet, and there's an understanding that this is okay and it's not stigmatized. But what happens in a regular EAP? I mean, and I know like private therapists have problems, you know, calling somebody on if they're having suicide ideation. So can you speak both what you do and in general about EAPs to that?
So I can speak to what we do. It's a great question. So you're right. So Adventist HealthCare is our internal organization that employs us, but then we have about 50 other external organizations. We have an access line, and that works 24/7. It's always answered by a licensed clinician. So if somebody from another organization was to call us and say, "I'm feeling like, you know, we always answer the call in a very standardized way so that we're screening right away for risk of harm or substance abuse when we first answer the call. So that'll tell us what direction we're going in, right? When somebody says, well, yeah, I haven't been feeling so, tell me more about that. So if somebody calls in and they are at risk of harm, we're not going to get off the phone until we've connected them with somebody that's either come to them or gotten another party, someone they trust, to get them to a hospital or to a crisis center. So we are holding their hand until they're at safety. Does that answer your question?
Yeah.
Okay.
Do you know anything about other EAPs and how they
I would hope that they would do the same. And actually, I would say generally EAPs that have access lines do the same. I worked on the U.S. Postal Service contract, which was a national contract for all postal services, and so all postal workers rather, and they too had an access line, and we did just the same. That you're as a licensed clinician, you are not going to disconnect that call.
Well, what about the process of bringing the person back after their crisis?
So we don't do, and most EAPs don't either, don't do any kind of fitness for duty. And again, that's their confidential. We trust that wherever they go and they get the treatment that they're getting, they're going to get a discharge plan. They're going to have follow-up. Maybe they went off their medication. Maybe they need new medication, that sort of thing. When they're ready, they'll come back. Generally, they'll probably get some Family Medical Leave Act or short-term disability or what have you. But there's no real process. It's, when they're ready, they come back. But we don't do a fit for duty. It's when they feel that they're ready to come back. Absolutely.
I have a question. Okay, thank you. I have a question about something you mentioned, Kathleen, but anyone feel free to answer. You mentioned workplace violence and that it's increasing. Can you elaborate on what specifically you mean by that, and then other trends you're seeing with workplace violence or other kind of conflict in the workplace?
It's a great question. I wish I knew the statistics, but they're definitely on the rise. And healthcare is one of the top 5 of where workplace violence is occurring. It's occurring mostly in the emergency rooms and behavioral health units. Folks are getting far more violent, and they're attacking our healthcare workers. And so there's a lot of conversation around how to protect our employees from that, and then what to do as a response. So as an EAP person, I'm more on the response end, right? Building in abilities to screen patients and family members when they come in, because it's not just patients, it's family members also being disgruntled. Well, the hospital might be understaffed, and why didn't that nurse come when we called? Well, she had so many patients and she's coming, or he's coming rather. So from the EAP standpoint, it's more of the response to that. And in our system right now, we've created this really great response, which is when someone is victimized by workplace violence, there's now a process in place that they are contacting, they're assuring that the manager is contacting occupational health, is contacting, we actually have a forensic medical unit in our hospital, and then they're also contacting the EAP. So we're making sure that the organization is really scooping up this victim and making sure that they get the proper medical care, they get the resources, and they get the proper after psychological care to the trauma. Sure.
This was a fascinating discussion from all three of you. Thank you so much for coming.
Thank you.